the isolated gastric varices at the fundus region. These two types of varix can be dealt with the endovascular methods. Before moving on to the procedure proper, I'll just highlight the vascular anatomy. Here, this is the portal vein. From the superior mesenteric vein and the splenic vein, the blood goes into the portal vein into the liver. Whenever the portal pressure increases, there is a diversion of blood away from the portal vein. So through the left gastric vein, this is the posterior gastric vein and short gastric vein, which leads to the formation of the gastric. So the gastric varices are fed by left gastric vein, posterior gastric vein and short gastric vein, and the drainage, this is all called as inflow or afferents. From the gastric varix, the blood goes out through the shunt. This is the gastrorenal shunt. From the esophageal varices, usually the blood goes out through the hemiazygos and azygos vein. Here, from the portal system, it is fed and it goes out into the systemic circulation through the gastrorenal shunt and into the left renal vein. So based on this inflow or afferent, we have the classification of gastric varices. The type 1, we have the single afferent vessel which supplies the gastric varices. In type 2, we have multiple afferents. In type 3, we have multiple afferents. Along with that, few of the afferents directly communicate with the shunt instead of going into the varix. We have this afferent. This is the gastric varix bed, and this is the afferent outflow. And based on the outflow or efferent, we have this type 1 where there is a single large shunt without any collateral. If there are collaterals which take away the blood from the gastric bed, this is shunt along with collaterals. This is type 2. And type 3, we have the gastrorenal shunt along with one gastrocaval shunt, two prominent shunts along with collaterals. In type 4, we don't have any large shunt. So we have afferent bed, this is a gastric bed, and the afferent is through multiple small collaterals. The importance of understanding this is we can treat predominantly these two patients, like by endovascular method, by obliterative method, that is the BRTO and modified BRTO, we can effectively treat these two. These two needs a decompressive procedure with the help of the tips. So, which are all the patient most suited for BRTO technique? Isolated fundal gastric varices which has ruptured with the presence of a defined gastrorenal shunt. We should have a prominent shunt to cannulate and occlude the shunt and obliterate the varices with the help of sclerosant. And those patients who had the overt hepatic encephalopathy, and also BRTO can be combined with the tips when the tips cannot completely decompress the massive gastric varices. For selected patients, BRTO provides excellent bleeding control while preserving the blood, preserving the liver function, because in BRTO, by occluding the shunt, we are diverting the blood back into the liver parenchyma. So next is the portosystemic shunt syndrome. This is the newer topic where when there is a large shunt which diverts the blood away from the portal vein, eventually the initial stage, the hepatic function will be preserved. Here there is a hepatopital flow, the liver function is preserved. As the more and more blood is shunted away from the portal vein, the hepatic atrophy ensues. There is a further due to increase in the shunt, the hepatic atrophy further increases with resultant decrease in hepatic function as well as the portal vein thrombosis. So how BRTO works in this patient? By occluding the shunt, we can increase. This is the normal mechanism. Once the shunt formation happens, the liver gets atrophied. By occluding the shunt, we can bring back the blood into the liver parenchyma and increasing the liver function. So by occluding the shunt, we can improve the serum albumin level by 85%, as well as the improvement in prothrombin time by 70%, and maintenance of the liver volume in up to 88% of these patients. But the important point to remember is when to occlude the shunt in case of portosystemic shunt syndrome. We all know, I mentioned about the improvement of albumin, prothrombin time, reversal of encephalopathy, but all this comes with the cost of increase in portal hypertension. Once we occlude the shunt, the portal pressure increases, which may worsen the ascites, exacerbation of the existing esophageal varices, and systemic thrombosis. The main thing is we should know the liver stiffness measurement. When the liver stiffness measurement exceeds 23 kilopascal, there is no point in doing the shunt occlusion, because still the patient even after shunt occlusion, patient will worse. So this cutoff we have to remember. Beyond this, we may not be able to treat the patient with BRT. So this is the updated clinical algorithm. Whenever there is a patient of upper GI bleed with isolated fundal gastric varices, patient will undergo endoscopy. Endoscopic treatment is done. If the endoscopic treatment, even after endoscopic treatment, patient continues to have a uncontrolled bleeding, we have to map the collaterals with the help of the CCT, and based on the afferent and efferent in type 1, in type A and type 1 afferent and type A and B efferent, we can go for a occlusive obliterative procedure, that is the BRTO. In type 2 and in type C, type 2 afferent and type C efferent, we have to combine with the tips and BRTO. In type 3 afferent and type D, that there where there is no shunt, only collateral, tips is the only treatment which we can offer. So also multiple randomized control trial have clearly shown the evidence of the uh, BRTO scores more over the endoscopic treatment. This is the Louis et al., which showed the bleeding rate is much lesser as compared to the endoscopy arm, which is 15.6 in the radiology arm, as compared to the endoscopy arm, which is 34.4 after the treatment of gastric varices. And 2-year rebleeding rate is lesser with BRTO as compared to endoscopy. And this is the another trial, Biswas et al., which clearly showed the 1-year outcome is better with the radiological arm as compared to the endoscopy. And this is the Bavino 7 consensus, which also clearly state BRTO is recommended as a safe and effective treatment for type 2 gastroesophageal varices, type 1 isolated fundal gastric varices, as well as ectopic varices. But very important thing we have to remember is it needs a clear patient selection. The patient should have a vascular anatomy which favors BRTO, and also availability of the local expertise. Very important thing, which has been mentioned in the previous talk also, there is no role for BRTO as of now in gastric varices, which in which patient who have not already blood unruptured gastric varices. So I'll showcase few examples which had been done from our institute. Any patients with a gastric isolated gastric variceal bleeding who underwent endoscopic therapy and who continues to have a recurrence should undergo a triple phase CT with negative contrast to delineate this afferent and efferent pathway. So this is the one of our patient where this is the gastric varices initially treated with endoscopic glue injection, and patient continued to have bleeding. We did a CT and we are mapping this shunt. We have to measure the narrowest point of the shunt to decide upon the diameter of the balloon or the vascular plug. So, a 42-year-old male, emptomesis, melena, known chronic liver disease, upper GI scopy showed large esophageal and fundal varices. And the initially emergency EVL of the esophageal varices were done. Patient continued to have a hemoglobin drop. So, patient underwent a CECT, which clearly showed this gastric varices, nodular type of gastric varices with the shunt. And this patient was planned for BRTO procedure. This was the balloon which was taken from the internal jugular vein. This is sheath. This is the reliant balloon which was advanced across the renal vein into the gastrorenal shunt, and mixture of sclerosant, air, and lipidol was injected into the bed of the varices after calculating the amount of sclerosant by injecting the contrast. So this is the balloon I can show you here. This is the occluding the gastrorenal shunt. We kept one catheter across the renal vein for confirming the patency. After inflating the balloon, occluding the shunt, there will be vascular stasis within the gastric bed, and we inject the sclerosant mixture till good stasis is seen. And with the indwell time of 4 to 6 hours, we keep the patient usually in the ICU. And after 4 to 6 hours, once the sclerosant nicely sets in, we take the patient again to the cath lab and we remove the balloon carefully. And this is after balloon removal, we can clearly see the stasis of the sclerosant which was injected into the gastric bed. And this is the post-procedure CT. We can clearly see the entire shunt as well as the gastric bed has been uh, covered with the sclerosant. And this is the follow-up. After 1 year follow-up, we can see there is no residual gastrorenal shunt or the gastric varices. So now we are modifying this procedure with newer technique, that is the plug assisted retrograde transvenous obliteration, PART-2, or coil assisted CARTO. And as well as if both this procedure may not be possible, we can go with the balloon occluded antegrade transvenous obliteration. All this depending on the specific photosystemic anatomy and operator experience. This modified techniques have advantage of shorter procedure time, because in BRTO, conventional BRTO, we have to wait for the minimum 4 hours for the sclerosant to set in. Here we can just go up, deploy the plug or coil, and we can embolize and we can come out shorter duration. These are all the various modified techniques. This is the plug. Instead of balloon, we can put a plug and embolize the gastrorenal shunt and the varix. This is the coil mass occluding the gastrorenal shunt, and we can inject the sclerosant. This is the modified carto. Instead of we place a balloon catheter along with the microcatheterism in advance deep into the gastric bed, and place the coil mass and occlude the gastric bed. And this is called Jerto, which has been widely followed in Japan, where they place the balloon, put few small coils, along with that gel foam is injected along with the sclerosant. This is the modified technique. So, case 2, 78-year-old elderly male present late evening around 7 o'clock to the hospital with massive UGI bleed. Hemoglobin was 4.6. Upper GI scope showed large gastric varices with blood clot. So this was the planning CT which we have done this patient. This is the gastrorenal shunt. This is the left renal vein. This is the narrowest point of the shunt, and large nodular type of gastric varices, which can be clearly, this is the shunt and the varices protruding into the abdomen. This is the stomach. This is the clot within the stomach. So this patient was taken for emergency BRTO. This is the modified BRTO Carto procedure. So we placed two catheters, one from the IJV, one from the femoral vein, cannulated the left renal vein. We went into the gastrorenal shunt. One catheter was advanced distally and one catheter proximally near the shunt. From the proximal catheter, we started placing the coils, multiple occlusive coils. Once the coil mass was good enough to cause stasis of the contrast, we started injecting the sclerosant. This is the sclerosant. This is the coil mass holding the contrast, and the sclerosant was injected. We can clearly see the entire anatomy of the gastric varices, complete obliteration of the gastric varices with the sclerosant. We need not wait here. So we coil mass is holding the sclerosant. We can just come off after this procedure. This is a post-procedure picture. Complete recovery of this patient from this massive GA bleed. This is a 58-year-old male, decompensated liver disease. Patient initially had a massive GA bleed, underwent a US guided coil placement of the for the gastric varices. Patient continued to have a recurrent bleeding, referred to us. This was the CCT done, which shows the shunt here, the gastrorenal shunt. This is the gastric varices, and you can see the coil mass artifact, which was done from the previous US guided treatment. So this was the part 2 procedure. So we entered the gastric varice bed from the femoral vein. This is the plug which we can see deployed, and we recaptured because we wanted to deploy further down. And this is the again this is the previous coil mass from the US guided embolization. This is the plug deployed. Few small amount of gel foam is injected here to occlude the pores of the plug, and we started injecting the sclerosant. So plug is holding the gastrorenal shunt, and we sclerose. So this is the post-procedure CT. We can see the previous coil mass and occluded gastrorenal shunt as well as the gastric varices. And the technical success rate can be close to 97% also, as well as the clinical success rate in the form of no rebleeding. And the few earlier complications which we can think encounter in BR2 is the post-embolization syndrome, which can be managed conservatively. Rarely, renal vein thrombus, pulmonary thrombus, and portal vein thrombus can happen. And the late complication, once the physiology alters due to increase in portal hypertension, we may encounter ascites and aggravation of esophageal varices. We should uh, uh, always inform the referring clinician to take care of this esophageal varices. And The takeaway for today's session is like tips and BO2 are effective, highly specialized tools address the portal hypertension because both have a different mechanism. In tips, there is a decompression, and BO2, it's obliteration. We also should have a patient selection individualized based on the vascular anatomy, clinical assessment, presence of encephalopathy, and the presence of refractory ascites. And it's a multidisciplinary approach, collaboration between the hepatology, gastroenterology, and intervention radiology to map the anatomy and intervene safely. Thank you everyone for your attention.
Thank you, sir. The forum is open for discussion and questions now.
Excellent presentation, sir.
Thank you.
You had mentioned liver stiffness measurement in terms of choosing a patient for BRTO. Is there any role for spleen stiffness measurement, sir?
Yes, sir. Yeah, nowadays, now it has come up with the same, like as you said, they measure, and basically before the complete stiffness sets in, the liver LSM as well as this SSM, like spleen stiffness is also, there is a role.
Because I think the last Bavino introduced spleen stiffness measurement, and we are awaiting the next one to see what they would have told more about it. Yeah.
Just a query from Dr. Rajesh, I want to. So in the gastric varices, now we have 3 armamentarium, endoscopy, BRTO, tips. So everything is complementary. So Bavino just mentions that BRTO is an alternative to endoscopy. But when to do BRTO, when to do endoscopy, we don't have any clear. So you are from a high volume center. So if you can tell what is your practice, it will be good for.
I think we have had 2 wonderful lectures on management of gastric varices where both endoscopic and IR methods were discussed. I'll just try to summarize that and add inputs from my side. There are 2 scenarios with which gastric varices can present to us. One is in a patient who has never bled. So you do an endoscopy, a routine endoscopy, and you see large gastric varices. So there is a confusion as to what should be done for that. Dr. Santosh has clearly mentioned that Bavino mentions that no intervention is to be done. But in our setup, many of these patients, because they will not come for regular follow-ups, many of these patients will come back with rebleeds. So what is to be done? So there are some opinion pieces, some reviews which have mentioned that if you do an endoscopy and you see very large gastric varices, what is very large? More than 2 centimeters on endoscopy, or if you see features of recent bleed, in such patients, you can, on a case-to-case basis, offer either endoscopic or interventional radiological therapies. So that is one. In our setup, we do follow that. There was an article by Dr. Sareen from which you have taken that first image. So he has given a beautiful table and he has mentioned that anything more than 2 centimeter meld of more than such and patients with poor liver functions, you can actually offer primary prophylaxis, whatever is available, endoscopy, EUS or IR, whatever is available. So we do at our center, we do that. We do offer patients primary prophylaxis if they can afford it. That is one. Second scenario is when a patient comes with bleed. That was your question. So we have endoscopic therapy, we have EUS, we have IR therapies. At our center, what we do is when a patient comes with a bleed, a UGI bleed, obviously endoscopy has to be done. There is no doubt there. There is no confusion there. Endoscopy has to be done. And on endoscopy, if you find large gastric varices which have bled, then in that scenario, an upfront endoscopic, or since we have EUS available with us, an EUS therapy is offered. Regardless of whether we have IR, whether we have PART-2, whatever it is, endoscopy therapy is definitely offered. So what we do is, now the thing is that EUS has advanced so much. Initially, the endoscopist used to put coils and glue in the variceal mass. Now people are targeting the feeders that are feeding the varices. And in fact, some studies have come up which target the efferent also, the drainage pathway. So the problem with EUS initially was that people used to say you will target the varix and the varix will go, but still that shunt is still there. So the varix will come back. That is why people were having recurrences after EUS. But if you target the feeder on EUS, if you target the efferent on EUS, you are probably going to take care of the entire varicose complex, including the shunt. So what we do at our center, I work very closely with gastroenterologists, and when they are doing an EUS, I am there in the room. So what we do is we try to identify the feeder first. Usually, if the patient is stable with a bleed, we get a CT done and then we do endoscopy. So we know where the feeder is. We'll trace the portal vein and then see whether the left coronary vein can be seen or the posterior gastric or the short gastric can be seen. If they are seen, we'll target that. We'll put coils, we'll put some glue. If that is not possible and the patient has multiple feeders, then you target the efferent. How do you trace the efferent? You see the left kidney. It can be beautifully seen on EOS. You see the left kidney, you see the left renal vein, you trace the left renal vein towards the IVC, and you will see that shunt draining into the left renal vein. There you put your coil, and on top of the coil, you put either a glue or sclerosant. And if you do that, you'll be taking care of the entire varicose complex. So that is how advanced EOS has now become. Having said that, if after EOS the patient still bleeds, then we do a CT and see whether the shunt is there, and then we offer PART-2. And the other scenario, after EOS the patient has stopped bleeding, still the next day we'll get a CT. If any residual varix is there, you will target with PART-2 or give them the option of a repeat EOS or endoscopy, whichever they prefer. So to answer your question, I would say depends on the local expertise and institutional protocols. If you have EUS available with you, I would recommend that you go ahead with EUS first, try to tackle it with EUS. If it doesn't work, PART-2 is always there. So there was one question during my talk also. So what we do is, you have a patient with gastric varicose bleed, you've done endoscopy, EUS, the patient has stopped bleeding. Next day, we will get a CT. There is no confusion there. We will get a CT and we'll see whether the patient has any other symptom of portal hypertension, whether there is ascites, whether there is any PVT, whether there are large esophageal varices, or the patient clinically has hepatorenal syndrome or hepatopulmonary syndrome, anything that can be tackled with TIPS. In those patients, we will offer TIPS if there is no contraindication to TIPS. So the idea is, if it's only gastric varices, nothing else, liver functions are good, no other portal hypertensive complication, then you just tackle the varices with PART-2. But if the patient already has other symptoms of portal hypertension, ascites, HRS, esophageal varices, then PART-2 has to be done, but you add TIPS over that if there is no contraindication to TIPS. So all in all, I think it all depends on what is available, what level of expertise you have, and the patient profile.
Thank you, sir. Thank you for summarizing. And now I request concerned intermediate radiologist Dr. Ilango to felicitate Dr. Santosh. I request Dr. Ilango to felicitate the moderators too.
Thank you, everyone. We'll move on to the next session. May I now request the moderators to come over to the stage. Dr. Tony Basil, surgical gastroenterologist from Sundarajan Hospital, Salem. Dr. Mithun Kumar, surgical gastro from Gokulam Hospital, Salem. And Dr. Deepak, consultant IR, SKS Hospital, Salem. Our talk will be now by Dr. Deepa Shri, senior consultant and clinical lead, IR department, Rela Hospital, Chennai. She'll be talking on portal interventions and liver transplant. Over to you, Dr. Deepa.
Good afternoon, everybody. First of all, I would just want each and every one of you to give a big round of applause for yourselves. Can you all do that? Louder. You can actually be. I know we are closing the lunch time, closer to the lunch time. The reason why I say this is, I don't know, I was actually, the previous talk was fantastic, but then, having been here from 9 a.m. in the morning, sometimes, our attention span is so limited, but it's a kind of a struggle to listen to every talk. So I think all of us, and it's also a proven fact that no TED talk lasts for more than 12 minutes. 12 minutes is apparently the attention span, and now with the Instagram reels, our attention span is less than 30 seconds. So first of all, you all need a big round of applause for sitting here, asking questions. And once again, thank you so much to the Salem team, Dr. Karthik and the entire team for having us over here. It's been wonderful listening to all the lectures, and it's nice to see the great work that you all have been doing. So I believe in the concept of Amazon rainforest, and I don't know if you have heard me say this before, but then we don't no longer live in the concept of savannah. We're not fighting territories here. We are all living in a, like the previous one that Dr. Rajesh has answered, whether it is EUS, or whether we need to do, TIPS or BRTO or endoscopy, whatever. So I think each one of us have got a role to play here. For example, in a forest, an eagle is responsible for the vision, an elephant creates the pathways, and the bees actually, they help in pollination, ants for their patience and effort, and lion for the protection. And that's how the ecosystem survives. And I think all of us, we are in that state wherein we complement each other, and we are no longer in a state wherein we are competing with each other. EUS can do wonders, IR can do wonders, and I think it's where we jump in, where we help each other, where we support each other. And I think that's the whole idea of this forum as well. It's a multidisciplinary management or the teamwork, and we are no longer fighting, and we are only collaborating with each other. So with that, I'm from Rela Hospital, and I have got a couple of other passions, wherein I believe in self-development. I've written a couple of books, and I'm also a neurolinguistic practitioner, which I believe really helps in the day-to-day management of our patients, talking to patients, counseling. So if any of you want to do NLP, please do NLP. It really helped me immensely in my practice. And that's my team. So always gratitude to my team. I have 2 fellows and a junior consultant. So without them, none of us would be here doing all the amazing work that we are doing right now. So no disclosures to make, and that's just a Rela Hospital. Extreme gratitude to Professor Rela, Mohammad Rela, for all the good work that he's been doing. And my exposure and my skill is mainly because of the amazing work that he has done. He's done more than 4,500 liver transplantation, and the pediatrics is probably one of the largest in the South Asia. So that's how I got my experience, and I'm deeply grateful for that. And although the topic is portal hypertension or the portal interventions in liver transplant, we have seen pretty much most of my cases of portal interventions are in a pediatric age group. We all know that the portal vein complications are very common in pediatric age group. Adults, we do see portal vein stenosis, but then most of the cases I chose only the pediatric portal vein interventions because those are interesting, and it's just that we all think, we all have surprises when you start doing the pediatric interventions, because we think, oh, it's a tiny body, the same equipment works, but there are certain nitty-gritties when we have to understand the pediatric portal vein interventions. So we all know, again, it's MDT approach. It's not that, IR always comes first. So from the most important thing when it comes to any intervention for that matter, post-transplant interventions, is do not wait for the graft failure. Do not wait for overt graft failure. So it's always a surveillance. It's always the clinical signs which actually needs to be picked up, which matters when it comes to any pediatric or adult intervention. And with regards to the post-transplant interventions, the biliary complications are probably very common. Next comes your portal vein. Had and has, you do come across, but not as much as the biliary complications. And then we have your hepatic. So these are all the spectrum of complications that you can come across after a adult LT or a pediatric LT. But in a pediatric LT, you see more portal vein complications compared to the adult transplant interventions. Why do we have portal vein complications in a pediatric? Because we know that, it's most of the times it's because of the graft geometry. In a pediatric transplant, you're putting the left lobe of the liver. Not unlike the adult transplantation, wherein you're putting the dominant right lobe, you're transplanting the left lobe. And when you transplant the left lobe, it's a very small left lobe is enough. Usually the mother or one of the uncles or somebody who is compatible, they end up giving the liver. And the lobe, when it hypertrophies, there is always some kind of a redundancy or some kind of a kink which happens when the lobe hypertrophies. And that's what happens in a pediatric transplant setting. So this is what is important. And also the graft tends to grow, right? So they're not like adults wherein the size is stable. They continue to grow. Kids are growing. And that is when the size mismatch also can occur. So this is important to understand in a pediatric transplantation. So the size mismatch which can happen, and so we all know this is what is responsible and we know what to do for that. Now, there are a lot of studies. I wouldn't go into the details, but just I would want you to focus only on the portal vein here. So the incidence we know is about 8 to 16%. Surveillance is the key. Now, the doubt is whether we go for venoplasty or whether we go for stenting. What do we do when somebody has got a portal vein stenosis in a pediatric age group? So the key is, the graft salvage, but these are all the questions that probably runs in some of your minds. When to intervene when somebody has got a portal vein stenosis, you see something on CT, so do we jump in and then do we intervene? Or what should, and if you decide to intervene, what should be the approach, whether it's a transhepatic, transplenic, transjugular approach, what should we do? When should we plasty and when should we stent portal vein stenosis? And what's the hardware in pediatric age group, and what should be the size of the stent if you were to deploy a stent in a pediatric portal vein? So when to intervene, again, we were discussing from this morning about the clinical signs are very, very important. So you're looking at the portal hypertension features, whether the child has got hematemesis, whether the child has got melena, ascites, all these things are very important. If they have the clinical signs, yes, we definitely need to intervene if you see on CT, hypersplenism, or even a graft dysfunction for that matter. And on imaging, you're looking at more than 50 to 70% stenosis because there is always going to be a mismatch. It's an adult portal vein to a pediatric portal vein. So you will definitely have a mismatch. But the criteria is at least 50 to 70% of the stenosis. Abnormal Doppler is what you're supposed to check. And the gradient is actually not a lot that we are looking at here. So we are just looking at even a 5 mm gradient is considered significant when you actually do a venogram, when you do a portogram. If there is a 5 mm gradient across the stenosis, we go in and do the plasty. And so the approach, I will show a couple of cases. I have about 5 cases that I will share today. But whether we do, I prefer, and most of the majority of the centers prefer transhepatic approach. It is a standard, pretty straightforward, easy for everyone. But one piece of, one thing that I really want to say when it comes to IR is all of us are skilled here. Each and every one of us sitting here, we know how to perform. It's like eagles, every eagle can fly, but knowing to strike with precision is what matters. Knowing when to circle, knowing what to do, how to do, when to do is what really matters. But otherwise, in terms of the technique, I do not think it is difficult to learn for anybody. Everybody can learn IR, everybody can do everything, but it's like knowing when to do, whether we should do or not. So which one do we go for? Transhepatic is a go-to approach. Transplenic, sometimes when the portal vein is completely occluded, the wire doesn't go through and there's a complete occlusion, a lot of collaterals, I prefer the transplenic approach because as we know, when we inject into the spleen, you see the direction of the flow towards the liver. When you inject into the portal vein, you see the flow towards the liver. You don't know where the narrowing is. The flow is in the opposite direction when you inject into the portal vein from the transhepatic approach. Whereas transplenic approach is easier. You know the direction, you know where it is going, and you know where to go. If you see the road, it is easy to walk down the path. So that's what happens. And transjugular, it's reserved for selected cases, like if there's coagulopathy, a lot of ascites, you can probably go for transjugular as well. And do you do plasty or do you do stenting? Always plasty. If it is a very short lesion and if there is no recoil after the plasty should do. Otherwise, you go ahead and stent. I will show in a couple of cases. And the hardware, we have the Sheba needle and the Neff set is what everybody uses, but I tend to use a mic. The Neff set has got the Sheba needle, which is very, very long. So in a very small pediatric child age group, that long needle is going to dangle along. So that's the reason why I choose a micropuncture set. A small micropuncture set usually works very well. So I use a micropuncture set, and then these are all the balloons and the balloon expandable stents that we can use, which I will show. And in terms of the sizing, these are all the approximate sizings, but every child is different. And nowadays, even a 7-year-old looks like a 14-year-old. So it's not like, we should stick to this sizing, but approximate sizing. Usually we don't exceed 10 mm or 12 mm for a pediatric age group. And so this we have discussed. With the interesting cases, this is one of our papers which got published a while ago. Just wanted to talk a little bit about auxiliary liver transplantation for those of you who are not aware. It's a case of a portal steal which happened, and which I will show as the second case. But this is a 9-month-old child with propionic acidemia, and there was a prolonged ICU stay in the neonatal period, and the child's uncle was the donor. So child went an auxiliary partial orthotopic liver transplantation. So what is auxiliary transplantation? I'll tell you what it is. An auxiliary transplantation is where you leave, you leave a bit of the native liver inside. Usually the right liver is left inside the patient. The left liver is the graft liver, majority of the cases. And what you do is you decrease the portal supply to the native liver, and so that there is more flow to the graft liver. So you decrease the supply by banding. Surgeons do hemi-banding, and they improve the supply to the graft liver. Majority of the times, the native liver should shrink and the graft liver should enlarge. That is what happens in an auxiliary orthotopic plant transplantation. This is switch. This is, we don't do this often. It's usually this one, right? And so this particular, now why do we do uphold? This is done because it's an alternative to whole liver replacement in a non-cirrhotic metabolic liver disease. Most of the kids have metabolic liver disease. They have oxaluria, primary oxaluria, they have tyrosinemia. These are all the diseases they have. And this OLT, because you are leaving a part of the native liver, it supports the graft if there is a graft dysfunction. That is the reason why you leave a little bit of the native liver inside the child's body. And in future, if there is a gene therapy, that liver can actually grow. So this is the reason why we use the uphold. So anyway, this particular child came back with a rise in the liver enzymes. You can see there was sudden short of the liver enzymes. And so the propionic acidemia, it's a little bit about it as to what this child had. You can go back and look at it. So when we did a CT, the right portal vein was already banded. The flow was towards the auxiliary liver. You can see like a hemi-transection in the liver, wherein this is a graft liver, this is a native liver. However, the graft liver continued to shrink in size because the portal flow was predominantly to the native liver. And so in such cases, IR plays a very important role. So what we had to do is we had to do a selective right anterior portal vein embolization. So when you do a selective right anterior portal vein embolization, the right anterior lobe is not much anyway. So they said just embolize that. And they wanted this right posterior portal vein to be there. So just, embolize the right anterior portal vein. And we can't come from the graft liver. It has to be ipsilateral approach. So it's pretty straightforward to go in and then do this. And then later on, you see an improvement in the child's, the graft volume has increased, the enzymes have improved. And so this is a selective portal vein embolization in somebody with an uphold liver, somebody with a metabolic liver disease. So the other portal vein complications that you can see is a portal vein stenosis. And the portal steal that I was talking about is something that I would like to show here. So this is a 5-year-old male child with situs inversus and biliary atresia. Sorry, this is not a portal steal. This is another case of a portal vein occlusion. Status post-LDLT in 2019 presented with features of portal hypertension. And this is what I meant. So this is a situs inversus. So you can see the spleen on this side and then the liver was on the opposite side. And in this particular child, we decided to go with a transsplenic approach because a transhepatic approach was pretty difficult. And even, the spleen was on the side of the liver. So it's easy to literally puncture because, there is no disorientation here. And so this is what we did. We came from the portal vein, and you can see from the portal vein, you don't know. This is what I meant. The flow is towards the liver, so you really don't know where it's going. And so we puncture the spleen here. and we try to negotiate. And once you negotiate, it's easy to understand where it is going, because once you puncture the spleen and then you put it across, you put the balloon, you can see the wasting there, and then finally we ended up putting a stent, and then later we coiled the tract and we glued the tract. So this is a transplanic approach in cases where transhepatic might prove difficult when you're trying to negotiate. And this is on POD day 4, I think, and there's a good portal flow and the child became all right. So this is a case of a portal steal, wherein this is a 12-year-old male child with biliary atresia and post-transplant bilirubin, came down and went up, biopsy showed rejection, and there was a portal steal syndrome. So what is a portal steal? A child already had a portocaval shunt during surgery, but then they felt that the portal pressures were pretty high, so they didn't want to obliterate the shunt. So they left the shunt. They thought there will be nice supply to the liver. So this is how it looks. You can see all these collaterals that you can see, because there was no portal flow to the liver. The portal vein is very small. The artery is bigger than the portal vein. And you are seeing there is a shunt which is going to the cava, and then you can see a lot of collaterals all the way in the abdomen. And so the liver enzymes were shooting up. There was also rejection, and this is when we had to do something. Unfortunately, the size of the shunt was more than 2 centimeters, and we could not get an Amplatzer plug at that point of time. And because the portal vein was smaller than the artery, when we punctured, ended up puncturing the hepatic artery, because artery was so big. And anyway, that has been sorted, but then we just had to puncture the portal vein from an alternative approach, go in there, and then finally try to see entire flow was only into the cava. And this is where we deployed a covered graft. So in these scenarios, you can deploy a covered stent within the portal vein so that there is an increased flow. So this is an alternative to surgeon ligating the portocaval shunt. But the child was not fit enough for surgery, and that's what we did. And you can see nice, I mean, there's still some flow there, but then there was a nice flow into the liver. And child was discharged, and there is a complete resolution in normal LFTs. Now, I have last 2 cases. I want to show when to stent, when not to stent. So this is a 16-year-old child, again, living donor transplantation 2022. And you can see, not sure whether you can play this. Yeah. So you can see, I mean, you really don't know where exactly the narrowing is, but however, we chose a transhepatic approach in this particular child. The images look very bright there, so I don't know, it looks okay here, but then it's very, very bright here. Anyway. So this is a portal venogram. We try to do venoplasty and okay. Okay, I just want you to look at this particular image where you see there is significant collaterals. So there is a portal vein stenosis with significant collaterals. This itself tells us that this child may not respond very well only to plasty, because the hemodynamically it is quite significant. Already the collaterals have formed. So this is not like an acute child came few months later. So the collaterals have formed. And this is where, sometimes only stenting will not help. So as you can see on the first one, I think we already deployed a stent in the second one. You can see the stent is deployed, but we still had a lot of collaterals. And so what we ended up doing is sometimes you just have to go in and coil the collateral so that there is improved blood supply to the liver. So this is how the pediatric portal vein interventions can be really life-saving, because there isn't anything much that could be done. And simple plasty may not work in every single case. And again, this is yet another case wherein we did exactly the same thing, portoplasty, but unfortunately the patient came back again after portoplasty. You can see we thought there was nothing there and it all looked fine. So it was simple portoplasty, discharged the patient thinking that, done the job, but unfortunately patient came back again with multiple collaterals. So we just had to, the patient also had PTBD in the same sitting. Because all these kids, they can have multiple problems, right? So PTBD and portal vein plasty was done in the same sitting, and the patient came back again, and you can see over here that there are multiple collaterals which are still persisting, and that is where the stenting helps. So it is important to understand that we don't stent these patients immediately. We do the portoplasty as a first approach. And if there is a recoil and if they come back, we can always go in and then do the stenting. And I think pretty much that's about it really. This is no different to the previous cases that I have already discussed. just to say that, stenting always should be taken as a second approach. This, I think Dr. Rajesh has already spoken about this, and I think that's just the part one of portal interventions. Thank you so much for your kind attention. Thank you.
The floor is open for discussion.
Yeah. 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 See, there is no other option, and anticoagulation also may not be an option, especially day 3, an aggressive anticoagulation, I meant. When we have to do mechanical thrombectomy, then I would probably prefer a transjugular approach, not a percutaneous transhepatic approach. So if we had to intervene, there isn't anything like we've intervened on day 2 also. For, let's say, for hepatic artery thrombosis, we've intervened on day 2. Recently there was one patient, they wheeled the patient straight from the theater where the hepatic vein got occluded immediately. So we don't know why it happens in a subset of patients, but then when it happens, when we have to do, I think we need to choose the right approach. Transhepatically going in and doing that intervention, I probably wouldn't prefer that, but we can always prefer a transjugular approach if required. But be careful about the anastomosis. That's about it. And have the covered graft and everything ready. Because if there is a blowout, one tool that we all must have whenever we intervene in such cases is probably have a covered graft handy. Just in case there is a blowout, just in case it ruptures, you can always pop a covered graft in.
Thank you. Thank you. May I now ask Dr. Jagdish to hand over the memento to Dr. Deepa. Thank you, Dr. Deepa, for taking your time off on a Sunday, coming all the way from Chennai. I request the moderators to stay back for the next session. Our next session will be by Dr. Shyam Kumar Keshav, HOD Interventional Radiology, CMC Valley. He'll be talking on IR management in hepatic venous outflow obstruction. Before he takes to the stage, my profuse gratitude to all the speakers. Probably the first time ever I have seen in any specialty meeting where every single person has stuck to their time. Thank you so much for everyone. You're used to being precise.
Good afternoon, everybody. Thank you for this opportunity, and I congratulate Dr. Karthik and team for organizing such a wonderful CME at Salem, and I'm sure this will enhance the patient care further. I'm from Christian Medical College. I work in interventional radiology. So I'm going to tell about Budd-Chiari syndrome in this presentation. Okay. So Budd-Chiari syndrome, this was originally described by 2 different doctors. I was initially thinking that Budd and Chiari, they may be friends. But if you look at the years of their experience, they are generations different. And what they have initially explained as regarding the syndrome, which has come with the swollen liver, pain abdomen, and what we are seeing and what we are treating today, they are slightly different. So basically the hepatic venous outflow obstruction. So that results in gradually over a period of time, we will see fibrosis and portal hypertension. There are different patterns. So if you look at the line at the first one, where there is inferior vena cava obstruction, and you can see the obstruction of the hepatic veins. And today we are seeing most often it is a combined both IVC and hepatic venous confluence. When you look at the imaging, you can look at the acute changes, what we see, or subacute changes and chronic. So in acute changes, we see thrombus formation inside the hepatic veins, so which may be hypoechoic or anechoic within the hepatic vein and or the IVC. Whereas over a period of time, these present with short segment of occlusion, or sometimes they appear like webs, because majority of the thrombus may resolve, but a focal obstruction may remain, and that can look like a web. And these are some of the typical appearance what we can see due to the blockage, where IVC is blocked and the outer wall of the IVC can be convex on both sides, and that we call as a Millard sign. And sometimes you may see multiple collaterals. So when we see multiple collaterals inside the liver, it is an indirect sign, but it's a very definitive sign that there is some amount of obstruction for the hepatic venous outflow. So this is the algorithm what we follow. Whenever we can open the obstruction, then the flow is established in the normal direction. In other words, functionally, we are achieving a normal flow to the liver. Whereas when we cannot achieve this, we reassess the symptoms of the patient. If the patient is significantly symptomatic, then we offer a bypass, that is a TIPS or DIPS. So it's a DIPS in case of Budd-Chiari syndromes, because we may not find a proper hepatic vein for connecting portal vein to the IVC. If you see physiological modification, what I'm telling is, when we do this, we are bypassing the flow to the liver. Over a period of time, something like 2 decades or 3 decades, there can be changes in the pulmonary artery, and patient may develop pulmonary arterial hypertension. So this one has to be aware when we are creating this kind of physiological modifications. I'll show some case examples. This is a patient who was symptomatic, and on ultrasound we can see the IVC is dilated. And when we examine these patients, I generally ask them to be in a sitting position. This is just like how we examine a patient with the varicose veins. We put these veins under pressure so that they can distend well. If the liver is shrunken, sometimes the hepatic veins can look smaller. Whereas if you make them to sit, they can distend as much as possible. Then we can differentiate between actual occlusion of the hepatic vein versus the compression of the hepatic veins due to the liver parenchyma itself. So this patient, we could easily go from the transjugular access. We have crossed the block, and here, this is the image what we see immediately post-plastic. Very short segment of the IVC narrowing, they open very well. So this kind of appearance, what we see, the external convexity on both sides, we have described as a minaret sign, compared to, this is the patient where the liver is grossly swollen, and that itself is causing the extensive compression of the IVC. If you look at the outer wall of the IVC, it is concave versus what we see in the first example. So this is another example where IVC is showing focal narrowing, but if you look at these veins, there are multiple small veins which are trying to compensate for IVC narrowing. The original hepatic veins are obliterated. So in this kind of patients, you see there is significant pressure gradient. We have plastic. With the plastic, this hepatic vein, this IVC segment has opened very well. Now, what about the multiple small hepatic veins which we see here? They were feeling very well in the beginning, whereas now they are not feeling at all. Is it a good sign or bad sign? The answer is, this is very good. Earlier, whatever the contrast we are injecting here in the IVC, it was refluxing into the hepatic veins. Now, the unopacified blood from these hepatic veins, they are coming so fast that contrast is not able to fill them. So this is a very good sign, and we don't have to make them anatomically normal. This is the functional achievement. The pressure gradient has reduced, and this kind of patients, they do clinically very well. Another case example where there is focal stenosis of the hepatic vein, and IVC is patent. So what we have done is, we have gone from transjugular approach, which is the first choice, and we have taken a transjugular liver biopsy cannula up to the ostium of the hepatic vein. Then we have manipulated a catheter and wire into the hepatic vein. So this is a middle hepatic vein, this is a right hepatic vein. These two are communicating, and this is the common ostium of these two, and they are entering into the IVC. But that ostium is occluded. So once you have gone across, which is achieved by a combination of fluoroscopy and ultrasound. By doing this way, what we have done is, we have reduced the time for intervention. By keeping a transjugular biopsy cannula or TIPS cannula at the tip of this ostium, it improves the grip on the intervention, and we can achieve this recanalization quite fast. If you see the result, there is brisk flow across this middle hepatic vein. Again, you do not see the right hepatic vein. Functionally, it is very similar to the previous case, what I have showed. The non-opacified blood is coming from the right hepatic vein, and it is aggressively flowing in the right direction. If transvenous opening is not possible, then we go for percutaneous. In this particular patient, there is no right hepatic vein, there is no middle hepatic vein. When I say there is no repairable hepatic vein, it means that entire hepatic vein is fibrosed. If the entire hepatic vein is fibrosed, we cannot repair it. If the ostium or a short segment of hepatic vein is blocked, then we can open, so that the tributaries which are drained to that hepatic vein, they can decongest the liver. But if the hepatic vein is replaced by a fibrous cord, there is no way we can repair it. So here, the left hepatic vein, we have percutaneously approached, and then we have passed a wire, and this wire we have snared, and then we have placed a stent. So this is done in our situation as a second option, where the first option is always we go from the transvenous. If physiological restoration is not possible, then we go for physiological modification. In this particular patient, who has got a patent IVC, no repairable hepatic vein, so we have planned from IVC to the right branch of portal vein. We have positioned the cannula. Then under transabdominal ultrasound guidance, we have taken a needle, we got into the right branch of portal vein. After that, we have passed a wire, we manipulated the wire, and this is the photogram what we have achieved. So once we get the photogram here, we dilate the tract, and if you see here, the tract is quite long. So this happens in Budd-Chiari patients, because the liver is so swollen, the tract is quite long. Whereas the regular tips, when you are doing, the tract will be in the range of something like 4 centimeter or 5 centimeter. This particular patient is about 10 centimeters plus. So even after placing the longest stent, we had to put an extension limb for establishing the flow. So this is a publication done by one of our colleagues, who is a radiation physicist. He observed that the radiation what we get by combining ultrasound along with the fluoroscopy is significantly less. Since we did not have a case control study, we have compared with the historical controls, where the radiation what we get is about 1/3 of the regular. I'll show a case example of a young boy who presented with significant symptoms, and you can see that there are multiple intrahepatic collaterals. We did an IVC gram. IVC was open at that time. We checked the hepatic veins. All these hepatic veins are very small. When you try to open this kind of small veins, the result is not that good. Initially, we used to do plasty and see how good is the result. But over a period of time, we learned that it is not much useful. Whereas he had another large vein, which is directed caudally. And you can see that the tip of this vein is occluded. So this is the caudate vein. We plastered it, and we subsequently stented it. That gave some quality life for him for some time. Subsequently, when we check, we can see that there is a new narrowing what is developing in the IVC. We plastered the IVC. There was some good flow. Then subsequently, we had to stent the IVC. It indicates that the underlying Budd-Chiari syndrome, the JAK2 mutation what it is having, is still acting on these hepatic veins and the IVC. So the disease is ongoing and it is not well controlled. This is over a period of time. He had several symptoms. And we can see multiple interventions we have done. We tried to open one of the hepatic veins over a period of time. That was not successful. Subsequently, we tried to do tips for him. But to do tips, what we have done is there is already a stent which is placed in the IVC. So we have to go through the wall of the stent and then we have to create a tips. So nowadays, what we are doing is when we place a stent in the IVC, we place a stent thinking that we should be able to go through the wall of the stent in the future. Whereas earlier, what we are doing is we used to place a strong stent, which will give the maximum radial force. That's a wall stent. Whereas if you put this kind of strong stent, what happens is to go through the wall is difficult. The tips what we create may not function well. So this is the switch over what we have done. So we did a balloon plasty of the wall of the IVC, and then we placed a tip stent. So this is called strut plasty. And in fact, this particular boy, for whom we treated about 25 years, and he is part of some 4 or 5 publications. Like this was part of strut plasty publication, and he had a long time follow-up, and he was doing well. And recently, unfortunately, he developed multiple foci within the liver, and biopsy was done, and that turned out to be hepatocellular carcinoma. So he had multifocal carcinoma within the liver, and unfortunately, he passed away. So, but he had a good life for a long time, and he was working well, and he was in a company and doing well. This is another lady who presented with Budd-Chiari syndrome. Multiple collaterals we can see within the liver. So what we did was, we kept her for an elective tips procedure. As she was waiting for the procedure, in 2-3 days time, she came with acute pain abdomen. So when we did ultrasound, we found there is something new. You can see there is a thrombus which has come in the portal vein. It was not there when we scheduled her for the procedure. So one thing what we are thinking retrospectively, she was on anticoagulation. We stopped her anticoagulation for the purpose of doing TIPS procedure. Perhaps this stoppage of anticoagulation would have resulted in thrombus formation within the portal vein. So what shall we do next? So as you could remember from Dr. Rajesh Sasidaran's talk, he had shown case of portal venous thrombosis, acute portal venous thrombosis, where TIPS was done as a treatment option. So this is the CT where you can see acute portal venous thrombosis. It is extending to the superior mesenteric vein. Remember, whenever the thrombus extends to the superior mesenteric vein, patient symptoms will be more. Whereas when it is within the portal vein, the symptoms are not that much. So we have gone ahead with the IVC gram. IVC is patent. Again, you can see the liver size is very large. We have taken a catheter here. We have punctured the portal vein. Remember, this puncturing of the portal vein is possible only if you are using ultrasound guidance. We do a transabdominal ultrasound, which is easier and it is cheaper. So when we hit this portal vein, which is thrombosed, we can see the tip of the needle on the ultrasound. But when you aspirate, there will not be any blood because it is filled with thrombus. So only the ultrasound guidance we go. We have passed this wire. If you see the orientation, the entire cannula is almost to the midline. That is because of the shifting of the portal vein more to the left side. The wire manipulation was very smooth, but is not looking like it in the superior mesenteric vein. So where it would have gone? Any guesses? Any guesses? But we are sure it is not in the peritoneal cavity because the wire manipulation was very smooth. So this could represent inferior mesenteric vein. So this is the venogram, how it looks. The blood is going more to the periphery. It's going to the mesenteric branches. And this is the initial photogram. Whatever we are injecting, it is going toward the spleen. We angioplastic. Then we place the stent. And after we place the stent, we did a thrombectomy, suction thrombectomy. And this is the flow what we could achieve. So this patient did very well. And she is on follow-up for several years now. And you can see there's a good flow and there is no ascites. So this case, when we did, we published as a single, we could publish as a single case report because this is actually a contraindication. We converted into indication. Now you can see there are several case reports and there are several papers on this particular topic. So not only we treated Budd-Chiari syndrome, we also could treat the acute portal venous thrombosis. So this is our radiological and clinical analysis of all these TIPS patients, what we have done for Bud Carey patients. And this is an interesting observation, what we see frequently. We puncture the right bunch of portal vein under ultrasound guidance, and we know that the wire is well within the portal vein. But if you see this venogram, the catheter tip looks as if it is outside the portal vein. You see a small gap between the catheter and the portal vein. So sometimes we get a doubt, is it outside the portal vein? So this we described as inside-outside sign. This is the line diagram to describe what happens during that time. You can see the catheter, which is stretching the wall of the vein, that is opposition of the anterior wall and posterior wall of the portal vein. That's why we see a small gap where there is no contrast. We publish it because this is a frequent observation. Once you start seeing it, you will see it more. This is a patient who had got renal function derangement, but patient was not on dialysis. On ultrasound, we could see the abnormality so well. So when the visibility is so well, we could take the advantage of this ultrasound visibility. We did this entire procedure under ultrasound guidance and fluoroscopy with zero contrast. There was no contrast injected during the procedure. So what we did was, once the wire was taken inside, we passed it to the right atrium. It went to the superior vena cava. We brought it down. We went into across the right atrium, and we put it up to the pulmonary vein, pulmonary artery, to make sure that we are well within the system. We have injected the contrast only to the balloon and nothing into the systemic circulation. And we finished the procedure, and there's a good clinical improvement. I just would like to highlight, imaging is very important. That helps in making a decision. Physiological restoration is our primary aim. Whenever that doesn't work, then we go for physiological modification. I just would like to highlight that this beautiful granite chain, which is made, this is a few 100 years old. And I saw it in a temple in a place called Bhavani. And if you see this beautiful structure, we still have scope for much more modification in technology. Our stent design, whatever we have today, I don't think we have reached this kind of skill level so far. So I thank you all for your kind attention. My last message is re-intervention in Bud Carey. It's a rule rather than an exception. So it is a long journey, and we keep involving in these patients, and we have to remember that it is multiple steps. Never ever they should think that I have spent 1 lakh and 2 lakhs and my disease is cured. Thank you.
The floor is open for discussion now.
Thank you, sir, for the wonderful presentation. I have a few questions. When to choose a transjugular or percutaneous approach for an isolated hepatic vein angioplasty, not considering the ascites and coagulopathy as contraindications?
This is a very important question. Our first option is to go through transjugular approach and then try to repair it from inside. So in which case we don't have to drain the ascites. We don't drain the ascites, number one. Number two, we don't correct the bleeding parameters. If the INR is within or close to 2 or 2.5, we go ahead with the procedure. If transjugular access IVC approach is not possible, we go percutaneous approach as the second option. So second option, it works well because the distance from the site of access to the site of intervention is less. But the prerequisites are, we have to drain the ascites, number one. Number two, we have to normalize the bleeding parameters. Still, there is a risk of patient developing hemoperitoneume and the risk of significant morbidity and even mortality is there. So this is the way we approach the patient. Nowadays, out of 25 cases, 23, 24 we can achieve from transvenous, especially after we started practicing the cannula assisted technique. When we do cannula assisted technique, it functionally reduces the distance. Though anatomically the distance is long, the functional distance is less because whatever manipulation we do through the metal cannula, the external manipulation we can easily transfer to the internal part where you have to cross the ostium.
And the anticoagulation regimen after procedures, sir?
Yeah.
in
We-
Budd-Chiari syndromes.
During the procedure, we put the patient on heparinization. After that, this is converted into acetone, and where we keep the INR between 2 to 3.
Thank you. If there are no further questions, may I now request Dr. Karthikeyan to hand over the mementos to both the speaker and the moderators. Thank you, everyone. We'll move on to the last session for the day, which is a panel discussion of case vignettes. Our speaker, or rather moderator, would be Dr. Naren, consultant interventional radiologist from MGM Hospital, Chennai. Dr. Naren, kindly come over. And our panelists who will be taking the stage are Dr. Gopalakrishnan, senior consultant surgical gastroenterologist from Dharan Hospital, Salem. Dr. Seduraman, consultant medical gastro, Kaveri Hospital, Salem. Dr. Madan Mohan, consultant IR from GEM Hospital, Coimbatore, and Dr. Praveen Keshav, HOD of IR, Sri Gokulam Medical College and Hospital, Thiruvananthapuram. May I request all four of you to take to the stage.
Good afternoon, everybody. So I have a few interesting cases to discuss on various aspects of portal hypertension. So going on to the first patient, he's a 55-year-old male who had melena on and off for almost 20 days. The last 2 days, it's been significantly increasing to the extent that he's present to the ER with hemodynamic instability, needing NORAD support. On the initial days when he presented with the melena, a UGA scopy was done. They found some varices in the stomach and in the duodenum, but there was no signs of active bleed. So nothing was done at that time point. Lower GI was also done, which showed altered blood in the colon and no active bleed they were able to find. So patient is not a known CLD, occasional alcoholic. To the medical gastroenterologist, sir, the patient has come to the ER now. What would be your approach, sir?
He had fundal varices, no esophageal varices per se.
No esophageal, fundal and duodenal, no active bleed, but still he is having persistent melena.
Okay. Then if fundal varices are found, I would like to tackle the fundal varices. If it's a bleed, melena is as active melena is there, active fundal varices. Like, what about duodenal varices? Where was it?
We have done the scopy twice.
Okay.
Both the time we have seen the varices, but there is no active bleed. But the patient is continuing to have melena.
Melena. Okay. Even though there are no signs of active bleed, if there is fundal varices as such, I need to tackle those, sir.
Okay, so how do you prefer to tackle it, sir?
Yeah, first I will do preferably glue. If I have a US approach, I will tackle it using a US coil. Better if I tackle the feeder. If it's not able to trace the feeder, I'll put it in the box. But repeated bleeding again after CECT, any gastrointestinal shunt is there or not? If it's CECT, preferably BRTO.
That was the next question.
Yeah.
When would you ask for the CT, sir? We have done the scopy already outside.
Okay.
Patient has come to our hospital.
Okay.
Would you first do a CT or would you take up for a repeat scopy?
If expertise is available, if BRTO expertise is available, I will do a CECT and look for the shunt, sir. Because in presence of shunt, if I inject glue, also there is chance of embolization. So better take a CECT and look for shunt.
Okay. Our hospital, we first did a CECT, repeat scopy. Repeat scopy, again, same, no active signs of bleed, both gastric and duodenal varices. And this is the CECT that was done at that time point. So Dr. Praveen, in case you're able to appreciate any findings.
So in these sections, we can see large gastric varices,
Okay.
and there is background CLD, portal vein is small.
Okay. There's a shunt as well, like sir was saying.
Right.
And apart from that, we can see the duodenal varices.
Yeah, in this section, we can see a few duodenal varices which are there.
Right. So at this time point, it was discussed with the gastroenterology team. Since we were not sure about the site of the bleed, patient was worsening and there was no site of bleed, would you want to suspect any other source? The CT showed no other source except for these two findings. Would you prefer to think, could it be like a small intestinal bleed, sir?
Possible, sir, but first water is visible, I'll just tackle those, and after tackling persistent bleed, then I will think of other sources.
Okay. We had a slight different thought process. Our gastroenterologist was not convinced that this was the bleeding source. So we wanted to he wanted to do a nuclear medicine imaging, RBC technetium scan to find out which was the active site of bleed. So that showed that the bleed was from a jejunal loop. There was an early active bleed from jejunum loops. Now what would be your approach, sir?
Active bleed is there from jejunal approach, then resort to an IR based management for a jejunal or endoscopy based management.
Okay.
Yeah.
So next, would you to Madan sir? So jejunum is the suspected source. We have two other varices.
Yeah.
So would you like to? And the report on the nuclear medicine was a early active bleed. So would you consider a arterial source, or would you think that is separate and it could still be a CLD related varicose bleed because CT was negative?
Usually arterial sources will be detected on a CT. If there is a vascular lesion, it will be detected on CT. But considering the nuclear medicine saying that it is early active early bleed, so I would look at the possibility of doing an angiogram, SMA angiogram, to look for any vascular lesions.
Okay. So we did the same. We did a angiogram. We didn't do a provocative angiogram. We did an angiogram. Selective runs were taken of different SMA branches, which was negative. The enteroscopy was also done by the gastroenterologist, who could go till like mid-jejunal loops where there was active bleed, but he could not find a specific point to treat that. Sir, to the surgical gastroenterologist, at this point, what would be your
if any active bleed, better we can observe in the ICU setting.
Okay.
Definitely there is active bleed. Then one thing is we can take the patient for intraoperative enteroscopy guided either resection or intraoperative guided embolization we can plan.
Okay. Would you prefer any interventional approach before that, or would you directly want to go for that?
If you can find a source, we can go for a intervention radiology guided either embolization directly with the one or two jejunal branches. Suppose we can block directly distal to that. Even jejunum we can tolerate ischemia up to even a 5 or 10 centimeter of ischemic zones. But if it is no active bleed, nothing, then we can plan for a observation. If it is rebleeding, then we can plan for a directly either laparoscopic or open guided.
So the patient was sick, ongoing bleed was there, hemodynamic instability. So we took up the patient for a TIPS, assuming this could be because of some unexplained jejunal varices which have bled, which could be a probable cause. Dr. Praveen, could you? What's happening in the first image?
So we have come through the jugular axis and we have gained the portal venous axis, and this is a portogram.
Correct.
So in the portogram, can you play it once more? Yeah. So in this portogram, we can see that the left gastric vein as well as one of the duodenal veins are the afferents, and the left gastric vein is draining through the splenorenal gastrorenal shunt, and
so yeah, these are the duodenal varices.
I think there was a phrenic efferent as well.
if you see the first collateral, these are the duodenal varices, which is going via probably the gonadal vein into the IVC, and that is the gastric collaterals going via the azygous and the hemiazygous system into the IVC. So the second image after stent deployment. So how would you interpret this? And
so after the shunt, we can see that the varices are not filling. Both the duodenal as well as the gastric varices are not filling.
so would you pursue and try to find out the bleeding point after this point, or would you like to wait and see?
Since the pressures have decreased and we have not actually found out that it is bleeding from the gastric and the duodenal varices, I think we can wait at this point.
So there is significant backflow. Whatever contrast we have injected, within 1 or 2 frames, it's gone to the heart. That means entire portal pressure has been decompressed. So we stopped at this point. The melena stopped gradually in 2-3 days. Hemoglobin stabilized. So probably there were small jejunal varices which could have been the cause in this patient. So a small companion case. This is a relative stable patient, sir, like how sir was saying. Almost similar findings. There was gastric varices, duodenal varices. So in this setting, a stable patient presenting with melena. Sir, as I think the gastroenterologist is already clear. I see something, I will tackle it. Sir, how will you tackle it? Patient is bleeding from the duodenal varix this time.
So if endoscopically, if they are unable to tackle, then we may have to intervene on this.
So sections are scrolling slowly.
Yeah, there is ascites, CLD. I mean, there's pleural effusion and CLD, and there is large gastric varices. And you said duodenal also.
Yeah, I think further sections are coming up. Now we can see the duodenal varices.
Yeah, now we are able to see the duodenal varices.
So,
and some amount of ascites was also there, perihepatic. Yeah.
So how would you, if you have to handle this patient, how would you handle this patient?
I would be thinking of, because there's both gastric varices as well as duodenal varices. And if I were to go in and treat the duodenal varices isolatedly, then there will be, and again, the patient is also having pleural effusion, ascites. TIPS would be a better option because it would reduce the pressure on the gastric varices as well as the duodenal varices. Yeah.
Right. So there are multiple decompensated areas. So if we block one, the other might work. Correct. So in case it's an isolated duodenal varix, sir, in that case, what would you do?
Isolated duodenal varix, we can try to go in through the systemic side, venous side, and try to get into the vein, which is the efferent vein, and do a BRTO or a PART-2 type of procedure or CART-2 type of procedure, if the anatomy facilitates that possibility.
So we'll go to the next case. 43-year-old male who was treated CA rectosigmoid, had liver mets. Ileostomy was done with LAR 6 months back, on treatment with chemotherapy for the liver lesions. Well preserved patient otherwise, no background CLD. Now comes with blood in the stoma bag. So this was the clinical at that time point. Those are the hands of our surgeon. Sir, now what would you do at this point?
Definitely, patient is bleeding from the peristomal side, probably from the varices. Venous bleed is there, and we have to see review the CT scan if possible. We have to see the liver status. If there is a sign of portal hypertension, we have to tackle the portal hypertension first.
Sir, would you manage it locally?
Difficult to manage locally. Just we can apply pressure, but it won't stop. It may be a temporary option. We need to definitely tackle it.
Okay. So as you told, some suturing was done, local therapy was done. It didn't stop. It stopped for a few hours. It worsened again. Why this video is important? The first video. This is a CT. While it runs, I'll just say why that first video was important. The history that was told. So okay, we can see multiple liver mets, ascites, splenomegaly, dilated portal vein, and large collateral that is arising, going towards the stoma side, and almost reaching up to the overlying wall here. So before I go on to the next, this is the MIP images showing the same. the discussion with the radiologist before was blood in the bag. So the radiologist said there's no active bleed. So the history that it is not bleeding from the bowel, but from outside the bowel is important in such a case, so that we can see any varices that can bleed. Anybody from the audience? Any two differences in the images? Is it possible? The first one is a pre-op 6 months old image. The second is the current image. Any difference apart from some post-op changes here? Sorry? Yeah, some hyperdense contents, but I'm not sure that's the contrast. Okay, so if you see the epigastric vessels, which was normal in caliber, now it has increased in size. The superficial veins, earlier it was symmetric, now these two have increased in size. So if you go back to our CT, you can see the parastomal varices has two efferents actually, which is draining into the superficial veins as well as the epigastric vein. This is important for us both while going antegrade as well as retrograde. So we took up splenic axis. So we have come from above, this is the SMV run. Dr. Praveen. So this selectively into the stoma, vein that's going towards the stoma. At this point, what would you do?
So basically it's a antegrade transvenous occlusion is what we are planning here.
Or in case you want a different approach, if you didn't want to do antegrade approach, what else you would have done?
Since there are only two efferent veins and both are superficial, we could have probably taken a selective access from the efferent veins individually from both sides, but we'll have to ensure that we retrogradely block those veins and make sure that the varices are filled, like how we do in PART-2.
Like a PART-2, but there are two efferents in this case.
Yes.
So that's why we went with a antegrade approach. Now what would you do?
So since it's an antegrade approach, I think we can use glue for embolization of the antegrade veins and the varices.
So we selectively cannulated, and because those veins were seen and they were superficial, we manually compressed while injecting glue and taken runs from there. This post-embolization where there was almost reversal of flow in the. So post-procedure, the nice glue cast as well as the tract that was embolized with coil, and so this patient improved after that. The last case, sir, again starting with a surgical kind of picture. Patient had a Spigelian hernia in the hypochondrial region, which was operated 5 to 6 years back. Known CLD, no decompensation. On follow-up, he develops a slowly increasing swelling. What would be your first thing?
First thing, you will order an ultrasound abdomen.
I expected that. So we did an ultrasound. Bunch of vessels, highly vascular. Next step.
Next, I'll go for a CT, ACT, contrast CT abdomen.
Contrast CT. Dr. Madan sir, I have select images of that.
Yeah, there are some just below the clinically apparent swelling. We have abnormal vessels, and it is I mean, the first image, the portal vein is also showed, so it is probably connected to the portal vein, left branch of the portal vein.
Yeah, right. So that's the left branch of portal vein.
And the subsequent images showing connection efferents going to the internal mammary vein and the superior epigastric veins also going below. Yeah.
So patient, what would you treat this?
Yeah, the surgeon has to decide.
Sir, now would you want to treat this? Would you send it back to us?
I'll refer to my colleague Karthik.
That's good to hear, sir. The same happened in our institute also. Patient is involved in security police kind of work, so there is a chance that it could bleed by contact trauma. So we decided to manage this. So for the audience, so these are the splenorenal, photosystemic collaterals that can develop. The dark ones are the portal sites. The blue, light blue ones are the venous sites where it can end up. So whenever the pressure increases here, all these are going to dilate and then finally reach a systemic circulation. And they have different names for that. We'll not go into it. So to reach any of the varices, which can either cause bleeding or it can lead to HE, there are multiple approaches. So the approaches can be either retrograde. Retrograde is through the veins. Can be antegrade. Antegrade is through the portal circulation, or direct puncture. Direct puncture is when we can directly puncture at the site of the varus if it's superficial. So based on the particular case, we can take whichever approach we want to do. So different examples, transfemoral, like a typical BRTO or a PART-2. When there's a recanalized paraumbilical vein, we can go through a paraumbilical vein, transjugular, transsplenic axis, and as TIPS axis, like most of us can do. So back to this case, Madan sir, how would you want to approach this? So there's a large portal vein, recanalized left side recanalized paraumbilical vein, collaterals draining into IMV and internal mammary and epigastric.
So yeah, so one option is go through the transvenous. There are two efferent veins. Go in, but we'll have to tackle them both.
Okay.
And do a BRTO type of procedure.
Through
retrograde. I mean, first maybe you can choose the internal mammary vein, and but it's a long pathway from the internal mammary vein. But we'll have to
navigate. The internal mammary, would you prefer a jugular or a femoral?
The venous, the CT venogram will decide which would be the best axis. Jugular might be difficult because it will go and join the subclavian vein, and you have to take a turn.
Angle at which it was joining was very acute for jugular.
Okay.
Yeah, so
maybe from the arm also. Arm also is one possibility, and the otherwise the femoral vein.
Okay.
But whatever it is, it's going to be a long route. Yeah.
Okay, so we went from the femoral, put a long sheet into the internal mammary vein, taken a run here. So we deployed a plug, and then we had not planned like a microcatheter to the plug, and we were not able to pass a bigger sheet, so we were not able to come from above. We punctured directly at the site of the after the plug deployment. On the third image you can see. So we tried to go as distal as possible. After plug deployment, we took runs, then injected glue with some sclerosant as well. So finally, transfemoral and the direct approach, combined kind of approach. The CT image post-procedure, glue cast, both above and below the plug, glue cast in the entire varices. So this is a follow-up after 3 months. This is a pre-procedure, post-procedure. You can see the swelling has nicely come down. The varices are completely obliterated. The portal vein size has also mildly increased probably. So that's portal plasticity, where when there is a flow in SPSs, the size of the portal vein will come down. But if the patient is otherwise not decompensated and we block a shunt, the size of the portal vein is expected to increase. That means the flow towards the liver is going to expected to increase, which is good for the patient functionally. Just one spotter for the audience. Anybody? Where have we started? Where have we reached? Any? Gone into the portal vein could have gone like this, I think. Something more straight. Yeah, okay. So this is the IVC through a patent gastrocaval shunt in this patient. So thank you everybody. I hope the cases were nice. I thank the panelists. They were very sportive. They didn't know the cases beforehand, and thanks for your participation. Any questions?
Sir, thank you, Naren sir, for this panel. I request Dr. Deepak to felicitate Dr. Naren. I request Dr. Naren and Dr. Deepak to felicitate panel members. We have come to the end of the sessions. Just a 1 minute for to thank all the people involved in organizing this event. So first, I want to thank Tnpy Isvir State Chapter for giving an opportunity to Salem to conduct this event, I thank Dr. Karapan sir and Preetham sir for the trust on us. I thank Dr. Deepak and Dr. Shantos, without whom this event is not possible. It was a women's support, and we had a good organizing team. And next, I want to thank our Dharan Hospital administration, the IT team, Banu, Purnima, Kartika, Veda, and Satish. So they were all working for so many days and for tolerating me and for, with all the administration. So I really thank the IT team because they're totally new to this. So we thought, okay, we'll do a live stream, but we don't have budget. So we asked our IT team, and they're totally new. This is the first time they're doing a live stream. So they worked, and I was really impressed the kind of quality of work they did. And I'm very thankful for the team. And I want to thank our my managing director, Dr. Selvaraj, who was a mentor and supporter when giving a guidance on conducting the event. And finally, all the speakers, chairpersons, and participants, and all our sponsors, Boston Scientific, Medtronic, Bolt, and Canyon, and Thermo. So they all contributed, without which this event is not possible. And thank you. We'll amend the sessions for lunch, and looking forward in some other meeting sometime. Thank you. Just one request, if all the IRs, if we can come on stage, we can have one photo and we can wind up for lunch.